Hi, I'm Dr. Morgan. I'm a family nurse practitioner. Welcome to Health Talk. Today, I will be talking to nurse practitioner Tamara Martin. She's a nephrology nurse practitioner, and we're going to bring awareness to kidney failure today. Hi, Tamara, welcome.
Hi, Dr. Morgan. Thank you for having me.
Okay, so this is a space where we are bringing awareness to medical conditions. I'm interviewing different healthcare professionals to shed some light into what we do. And you're going to tell us today, what you do as a nephrology nurse practitioner. So go ahead and give us a little explanation of what you do on a daily basis and what your role is.
Okay, great. Thanks for having me. And I'm grateful for this opportunity to talk about chronic kidney disease. Again, I'll reintroduce myself. I'm Tamara Martin. I'm the nurse practitioner with working in nephrology. Prior to becoming a nurse practitioner in nephrology, I was also a dialysis nurse with over 10 years experience. I currently work as a nurse practitioner. I'm a family nurse practitioner, but of course I chose to do specialty because that was my passion. I currently work alongside, of course, a board certified nephrologist here in West Texas. So on a daily basis, my role includes, I do from chronic kidney disease to patients who have end-stage kidney disease. I also see patients in the hospital who have what we describe as acute kidney injuries, which could be from could be any reason why they end up with an acute kidney insult. So I see both patients who should have normal kidney function but have an acute insult, monitor them to kind of figure out what is the primary cause, if it's reversible. Also, patients who have chronic kidney disease, the whole goal of seeing those patients is to identify what was the cause again and educating those patients on a daily basis how to prevent further worsening. And of course, I also see those patients who are declared end-stage kidney disease that are requiring some amount of kidney replacement therapy, which is dialysis, whether it be in-center dialysis or home therapy dialysis. So in a nutshell, I take care of everyone in the realm of kidney disease.
Okay, thank you so much for explaining. So with my research, I see that chronic kidney disease affects more than 10% of the world's population, which is over 800 million people. And the main causes are diabetes, hypertension, obesity, and both Tamara and I worked at the University Hospital of the West Indies in hemodialysis, and also I think we probably worked in peritoneal dialysis as well. So Tamara have a lot of experience as a dialysis nurse because she brought her experience and training from Jamaica, and then she came to America and continued in the field and then became a nurse practitioner and also still giving back in the area of as a nephrology nurse practitioner. So you've stepped away from the bedside, I would call it the machine side.
and I still do, I don't do much, but the joke about it is that when I am rounding in the dialysis center and the machine alarms, I can reset that machine and then I can do the adjustments, and the nurses are always in awe because they're like, nobody else does that. A provider doesn't do that. And I was like, well, I'm a dialysis nurse first.
Yes.
So it never leaves you.
Yes. So you stepped away from the chair side, and you still have the knowledge of what dialysis is. So you have a better understanding, actually, of what it means to dialyze a patient and also to create those dialysis orders. So in a nutshell, you did give a little bit of explanation of chronic kidney disease, but how do we prevent it? Because the general population don't know about kidney disease, and if they do know about it, they don't know how to prevent it. So what are some of the ways that people could prevent CKD?
So of course, so where I will start, Cheryl, is giving a little brief overview of what chronic kidney disease is. So chronic kidney disease is classified or described as a slow, gradual, irreversible decline in kidney function. Now, there are 5 different stages of kidney function. Stage 1 is where the kidneys function 90% and above, and that's considered very normal kidney function. Stage 2 is where the kidneys function 60 to 89%. And stage 3 is where the kidneys function 30 to 59%. Stage 4 is 15 to 29%, and less than 15% is what we classify as stage 5, likely getting to the stage of declaring you end-stage kidney disease, needing some form of replacement therapy. Now, as I described it as a slow, gradual, irreversible decline, a lot of patients are unaware because the symptoms of chronic kidney disease most times are not noticeable until you're severely damaged, where you start experiencing the nausea, the swelling, overall fatigue, just not feeling well. And especially for those patients who do not seek medical care on a regular basis. Now, some of the major causes, as we discussed initially, they include diabetes, high blood pressure, and obesity. Now, as far as diabetes, adequate glycemic control is very important. Going to your primary care or endocrinologist, getting that A1C under control is very important. Maintaining good blood pressure control, because as a diabetes educator yourself and somebody who's zeroing on diabetes, you know a lot of our patients end up being diabetic before they become hypertensive. And even though we have started them out on a little of medication to lower the, preserve kidney function, overall, after a while, those patients become hypertensive. Now, these are the primary causes. Now, patients don't know their numbers when they go to see the doctor. That's one big problem. They've been seeing a doctor for years. Your labs are okay. Nobody has, the capacity, or most of them, to say, what does my kidney function look like? And then primary care doctors are allowed to manage kidney function. Some of them will manage it even less than 60%, but I recommend that once that patient kidney function is 59%, 1 mark under 60%, refer that patient to a specialist. And I say that not because they're not competent in managing patients around in that stage of their kidney function, but I have more time to spend with the kidneys. When you see a patient in primary care would have high blood pressure and diabetes and high cholesterol, anxiety and depression, you have very little time to spend with that patient to educate that patient, properly about the preserving the kidney function. Again, I always say to my patients, the kidneys don't hurt unless they're obstructed or infected. So you can have a slow gradual decline and you just don't know. So that is why it's important to ask your primary care doctor, how are my kidneys doing? So medication wise, we may look at it too and say it's high blood pressure, diabetes, and and obesity. But then there are common practices among our population that can lead single-handedly to reduce kidney function without a history of diabetes, high blood pressure, or obesity. You will be surprised that many patients do not know that taking ibuprofen, Motrin, meloxicam, Celebrex, Advil, Aleve, those medications taken daily single-handedly for several years can contribute to chronic kidney disease. And those medications are available in the supermarket, Walgreens, everywhere, every corner you can find those medications. They work well for pain, but slowly, gradually, single-handedly, I have several patients that was the only cause of their worsening kidney function. Other medications include the medications that we use for acid reflux, the purple pill, as we all know, the Nexium that is in, and the Prilosec that is on the shelf that everybody can reach for. Now, acid reflux is real, and I will not diminish the effects of it and how uncomfortable my patients are. But it was meant for a short-term use, not long-term. And I find a lot of my patients that are on those medications, the Protonics and the omeprazole and the pantoprazole and the purple pill and the Prilosec. You say to them, how long have you been taking this medication? And they're like, oh, several years, 15 years, 20 years. Do you have acid reflux? No. So, well, my doctor gave it to me and then we just keep refilling it. And these patients maybe had a flare of acid reflux and they just keep refilling that medication without any evaluation. And I think that's one of the other things that we need to do is medication, pay attention to medication reconciliation when we get these patients. Now, so outside of what we would say lifestyle practices or things that are preventable, the diabetes, high blood pressure that can be managed, these are common practices that 95% of the population is not aware of. And these are the most common causes. And of course, we will go back to and we'll discuss as far as causes. And the reason why I'm spreading out the causes is that I have patients who are not diabetics, that they don't have high blood pressure, but even just a simple family history of chronic kidney disease. You're born with small kidneys. Different things can cause chronic kidney disease. And so that is why, again, knowing your numbers is important so they can be evaluated. Somebody who has recurrent history of urinary tract infections, repeated exposure to antibiotic therapy, that patient who wants to pay attention to their kidneys, because what filters urine? The kidneys. And so therefore, it's important, and I'm putting this information out there that anyone who is listening, if you have a history of recurrent urinary tract infections or kidney stones, this is something that you want to ask your urologist or your primary care doctor who is managing the UTIs, what is my kidney function? And so these are ways that once you find out, then we can, do you need a referral? Do we need to look further? What can we do to reduce the risk?
Okay. Thank you so much for that detailed explanation. And you have touched on some very, very important points, because a lot of people don't know that these simple taking of these medications over the counter can actually contribute to kidney failure. You mentioned a very important thing about primary care doctor referring patients to you whenever their GFR is less than 60%. In my practice, because I treat diabetic patients, and all diabetic patients are put on an ACE inhibitor. And for people who are watching who do not have medical knowledge, ACE inhibitor, any of the blood pressure medication that ends with pril, lisinopril, captopril, right? So my thing with this ACE inhibitor, when JNC guideline, JNC 8 came out, there was a little bit of controversy regarding not prescribing this medication for African-American patients. And I'm going to put you on the spot because I still do put my patients on it because I see that it helps them, and one thing I noticed though, once their kidney function worsen and I say, you know what, let me stop the ACE, let me send you to the nephrologist, they come back to me with a higher dose of ACE inhibitor. So you're going to explain to me why.
Yes. So there is, just like we said, there's a time and place for everything. All right. So remember, I touched on it that most of a percentage of our population will have diabetes before becoming hypertensive or high blood pressure. Now, these patients, remember what are the main reasons why we put them on an ACE or ARB, which is a captopril, enalapril, lisinopril, or the ARBs, which is a losartan, the telmisartan, or the valsartan. Is there something that is called hyperfiltration, which is high blood pressure inside the kidneys. Now, that in itself can over time cause worsening kidney function. most of our patients, when we recognize not only being a diabetic or high blood pressure, when we do the urinalysis and we see that there's a degree of proteinuria, which is losing too much protein across the kidneys, suppressing and reducing the hyperfiltration, which is high blood pressure inside the kidneys, is very important. And this is where the losartan, the lisinopril, the captopril, the enalapril comes into play. Because these medications are important in reducing the hyperfiltration, which is high blood pressure inside the kidneys, reducing the risk of worsening protein in the urine. Because single-handedly, losing too much protein, there's something that is called nephrotic range proteinuria, when you have several grams of protein spilling across the membranes of the kidneys that can continue to wear and tear on the kidneys. And so that is why we do the lisinopril, the captopril, and the enalapril to reduce the risk of worsening kidney function. And not only that, lisinopril or any of the prils or the ACE or the ARBs, as we know that's the group, also is cardiorenal, it offers cardiorenal protection, because then remember that somebody who has high blood pressure, the ACE and ARB is also important. And so we put them on it for cardiorenal protection. Cardio mean heart, renal mean kidney. So it's a dual purpose at that point. Because remember now that the heart gives the kidneys 25% of what it puts out. So preserving cardiac function is also important in preserving kidney function. And so that is why it's important to keep these patients on an ACE and an ARB. Now, do we monitor them for worsening creatinine, which is what the kidneys filter, what we look at to see that there's some degree of worsening kidney function? Yes, we do. And if there is advanced kidney disease, somebody who is stage 4, stage 5, even if they have nephrotic range proteinuria, which is a lot of protein across the kidneys, we'll pull that ACE or ARB for many other reasons. Those medications allow the body to hold on to potassium. And so the potassium, because a lot of those medications are potassium, losartan, whatever it is, the combination or the base of those medications. Now, the kidney's ability to get rid of extra potassium with reduced kidney function has reduced. And we all know what high potassium can do, very critical. Slow the heart rate, cause a cardiac arrest. So there are different cases that will take it off. So yes, there's always a little bit of controversy, but that's the main reason why we use the ACE and the ARB. It's a somebody with protein in the urine. You know, of course, I always describe the kidneys like a strainer. Now, the goal of a strainer is to prevent large particles from coming across. And it's the same thing. The protein particles should be too large to come across the kidneys. And so spilling protein in itself across the kidneys is an indication that there's even maybe an acute kidney injury going on because you're spilling some protein. Now, if that protein continues to go across those tiny membrane over time, wear and tear. Now, so if there's high blood pressure inside the kidneys, then what that does, provide more pressure to push that kidney protein across the kidney and continue to wear on the membrane. And so, yes, it is important in slowing the progress of chronic kidney disease.
So back to the JNC guideline regarding people of color and the ACE inhibitor. If they recommend not putting these patients on it, what would you do, or what do you do in your practice?
So I put all of my patients on it, and it's widely documented that there's risk of angioedema, which is the most common side effect of using, which is swelling of the mouth and throat. People can't breathe and everything, and sometimes even require a ventilator. Now, there's the risk, and it's a well-documented side effect, cannot be minimized. I do put my patients on. I'll do, instead of the ACE, it's more common with the ACE, which is a lisinopril. I'd say, but more common so with the pril, the lisinopril, the ACE, but not so much on the ARB. So I'll choose to do an ARB over it if they can tolerate. Now, if it has been a severe reaction, then I just take it off. I'll just document, because you'll be surprised that while JNC8 says that, the insurance company writes me and said this patient has chronic kidney disease and diabetes and is not on an ACE or an ARB. So it is
political world in the healthcare field. You're saying, okay, who went to school here to do what we have to do? So it's reimbursement, as you know, we call it value-based purchasing. Do we get reimbursed if we're not adequately managing this patient according to the insurance guidelines? So of course, again, but we're treating the patients, but we always, Mike, I always ask any allergies. If they don't, then I put them on a low dose. If they do well, I'll keep them on it. If not, I take them off.
And one of the things that I do, I educate the patient to look for angioedema. So, they're aware of that. So this brings me to my next question. I've seen patients with that slow progression of kidney failure, and they feel fine. Kidney is not hurting, as you said, because it's not obstructed. And when it is time for them to be on dialysis, it's really, really a big issue for that patient. I'm still passing urine. Why am I going to go on? And even though the nephrologist is explaining to this patient over the years, I had a patient where the doctor told him that, okay, you have another year before I put you on dialysis. So just enjoy this year. You know what he did? He went to Jamaica and had a ball. Then he came back and said, I'm ready now to go on dialysis. So what are the treatment for CKD in different stages? Because definitely not every stage will require that replacement therapy.
So replacement therapy is mainly meant for patients who have been less than 15% and start having what we call uremic symptoms, where, and I will say to you, Cheryl, I take care of these patients daily. And one thing I get from my patients is that I take the time out to educate, empathize, and share with them that if they have to do dialysis, we will not start dialysis unless it's absolutely necessary. It is only if we have done every medical management that we're allowed to do and that has failed or you have maximized, then we will start. Because in all honesty, it is a life-changing event. And so therefore, we wait as long as we can. Now, again, like I said, for patients less than 15%, that's where they'll allow us to declare this patient as end-stage kidney disease. There are a few, what would say, anomalies to the whole CKD, less than 15%, because again, if this patient has poor muscle mass, and of course, remember that creatinine is muscle and it's breakdown of metabolism. If this patient has poor muscle mass as well, like looking cachectic, don't have, the Jamaican people will say maga. This patient doesn't have enough muscle to filter anyway. So at the same time, or to break down to filter. So in that particular patient, you may look at their kidney function and they look like even a stage 4, like 21, 22% kidney function, but they're having the classic symptoms of worsening kidney function as somebody with less than 15% would show up with. So these patients now, of course, if we can document clinically, or patients with heart failure or anything, or volume expanded or something because they have too much fluid on board, these patients too can also meet the criteria, but of course it takes a lot of documentation and trial and error, 24-hour urine check it, see how much protein they're spilling, what is the creatinine clearance like in a 24-hour period. Now for our patients who end up with end stage, for true end stage kidney disease patients, again, like I said, it's a life-changing event. We start, per guideline, we need to start having the conversation with our patients once they get to around 20%. Now, we start having a conversation early. So we don't pounce on you unless we're meeting you for the first time and we have no choice but to pull the bull by the horn and say, this is it. We educate, we give our patients time to ask the questions, do their own research, come back, talk about the different modes of therapy. And so the different modes of therapy include home therapy, which the government is pushing for by 2025, that most of our patients do their dialysis at home to avoid the cost burden to centers, staffing and everything. And of course, I'd written up
a paper on that to co-author with two more nurse practitioners about patients meeting that criteria 2025 for home therapy. Now, there's home hemodialysis and there's home peritoneal dialysis. There's in-center dialysis where patients go 3 times per week. You know, they create that access in the arm that's called the fistula, joining that large blood vessel, small blood vessel together to give adequate blood flow so we can clean the blood at a certain pump speed on the machine. There's home therapy, but of course you have to meet the criteria. The house has to be in good shape, ventilation, infection, because there's risk of peritonitis, which is infection of the peritoneum of the abdomen. So these are things that we take in consideration if the patient has support. Now, one other thing that I push for is transplants. So if my patients are morbidly obese, and of course you have to have a BMI around 35 or 30, some centers, each center kind of have the little ballpark, they give a little break. And since COVID, and I spoke with one of the transplant doctors, he said that they kind of change the BMI a little bit because a lot of people gain so much weight over the COVID to being at home. Now, I encourage these patients, if it's bariatric surgery, gastric sleeve, lose the weight, get on that transplant list. I try my best to, at 20%, my doctor and I, we work together. We encourage our patients to start the transplant workup around 20% thereabout. So in that time, you know, where they have time, if it's cardiac clearance, because the heart has to be healthy, you know, work them up, they'll be already listed, gaining that time, because, you know, it's kind of a 5-year waiting period unless you have a donor, a live donor, to get yourself on the list so you earning time before you get to a dialysis center. And we've had a few success with that, where patients are actually transplanted before going on dialysis because we started early. Now, there are so many drawbacks in getting therapy again, you know, where that is concerned. One, support, and are these patients adequately funded? So there's a bundle, you know, the ESRD bundle that, you know, the insurance will pay for treatments, but then of course you have to be working, they call it working quarters, up to 10 years, I think, to qualify for ESRD Medicare. Now, you'll get that ESRD Medicare and you still would have to buy, I think there's what they call the subsidiary. You still have to pay for that. So sometimes there's a little bit of, you know, and you know, here in Texas, Medicaid is hard to get, for especially those who don't qualify for ESRD Medicare. Now, paying into the system, that's the only way you will qualify for ESRD Medicare. Now, we do have funding for the undocumented too. As we know, we have those that come to the ER ever so often.
We call them frequent flyers.
Let's put it in a nice way. We provide compassionate dialysis.
Compassionate dialysis.
Yes, that's what we call it, compassionate dialysis. And so what my hospital has done lately, there's something the American Kidney Fund will pay for undocumented patients. The social worker can apply for funding for those patients. And they'll provide for them, providing that whatever they have is, you know, even less than even low income individuals who are American citizens, less than $30,000 a year. So you really have to be about, let's say, 500% below the poverty line, and they'll provide that funding for those patients.
So if you're out of that category, you're pretty much gonna have to come up with the cash to pay for your dialysis?
So the American Kidney Fund will fund you if you're way below that line. They will pay for your dialysis for you.
But if you're not below?
But if you're not below, you're gonna be struggling to get that done. What they'll encourage you to do is to buy insurance through the marketplace. You can find something according to your bracket. You know, the marketplace will always provide something. If it's even up to $35 or whatever you can afford to pay monthly. Now, the only disadvantage to that is that when you do that, of course, you need the Part B or the Part C and medication, all that, D to pay for medication. So it's a little bit of work to get those patients adequately funded. Now, what my hospital has done lately is those patients who we call the frequent flyers, or ones that we actually provide compassionate dialysis for, is that they have come up with a plan, because it's very expensive when this patient comes to the ER. The ER visit, you know what an ER visit can be, even with us who have insurance, very expensive because it's considered acute care. So what they have done, so when they come to the ER, not only emergently, that's a cost, they take up a bed, 3 meals, depends, those patients tend to come late at night. So what happened? You call the dialysis nurse for emergency dialysis. You have to pay that nurse overtime, on call. So anywhere you take it, it's like more costly. So what they have done is to come up with a plan to say, okay, if this patient is really doing this over a period of time, they don't offer it up. They evaluate each case. They will say, okay, we'll place this patient and we will pay for it. Because out of pocket dialysis costs is like about $400 and something, near $500 per session. And even if you have ESRD Medicare and you did not buy Part B, you still have to pay that 20% out of pocket. You still get a bill.
And that is 3 times a week.
And that is 3 times per week.
4 weeks per month for the whole year.
For the whole year. And when you think about it, it's even more costly when we have those patients that are admitted under an acute circumstances that require dialysis inside the hospital. Those acute care dialysis, they're far more expensive.
Yeah. Another thing that I remember, Tamara, being back in Jamaica, where somebody would be, financially stable, end up with renal failure. I remember a patient choosing his daughter college tuition over his dialysis treatment, and he went home and died. He said, I'm not going to spend that last money that I have. I prefer to let that $1 million go towards her education. And it's a very tough decision to make. So when somebody is diagnosed with kidney failure, what life changes is expected in these patients? And we already know that there's a financial life change right there, but in terms of the job and living with kidney disease.
So this is one of the things, Cheryl, that is why I think, in many areas we're pushing for home therapy, because if you do home therapy, so the home hemodialysis is done about 4 times per week, shorter sessions. So if you choose to do home hemodialysis 2-3 hours per day, 4 times per week, it's more effective anyway. It's less pressure on the body. And you're cleaning the toxins, because if you think about it, under normal circumstances, a kidney is filtering every second, every hour of the day. And so we get rid of our toxins, and if it, build up. The toxins cause inflammation, make you feel tired and everything. Now, somebody who is doing dialysis more frequently should have a better outcome, as in lifestyle, how they feel, appetite, energy-wise, everything. Now, if we move to where we can meet that guideline goal of having patients doing more home therapy. Now, if they do home therapy at their convenience in the evenings after work, they can go to work. So they can still feel integrated in society and not feeling that, as Prof. Martin would say, avoid the connotations, a dialysis, a renal diet, the worst thing, our patients are never compliant. We all know if it's mango season in Jamaica, it's mango season, and if it's that they can't find to eat, that's what they eat. Now in Texas, or I can say America in general, but in Texas, since this is the experience I have, when it's watermelon season, it's watermelon season, and it's water and potassium, right? So we battle either way. In Jamaica, we battle mango season, but in Texas, we battle watermelon season.
And in Texas too, Texas is very hot at summertime. In Jamaica, when we were dialysis nurses, summertime, we used to lose a lot of our patients coming with fluid overload and eventually dying.
Yeah, dying, right. So you'll find that, so as far as the lifestyle and the changes, you know, is if they can do home therapy, if they're a candidate for it, because not everybody's not a one size fit all, then those patients can go to work and feel integrated. Like we spoke about losing the income, diet, exercise, and again, so these are the major things that the changes that will happen. Now, living with chronic kidney disease, I will say, even though it's irreversible, if I were to choose, God forbid, there's replacement therapy for the kidneys, and the life expectancy up to 10 years for most patients. But we have had patients, we know that live over 20 years, 25 years. We have one patient, who won't call it a name, she's still there in Jamaica.
Are you kidding me?
She's still there, Cheryl.
Yes.
She's going on. And it's a number of years.
That's probably about 30 years now.
That's probably about 30 years now. So there's an individual, you know, it's a case by case. And I find that not only with chronic kidney disease, it's with everything in medicine, family support. We all know that as nurses at the bedside, the patient that does the best is the ones that have family showing up. Because somebody cares, somebody will stop to talk. But if we don't have anybody to talk to, nothing gets done, or very minimal. So family support, and of course, I think a lot more, we need to do a public education campaign on chronic kidney disease. We have public education on breast cancer. We have public education on heart disease. We have public education on now colon cancer that is taking over earlier than 50 years. We have public education on everything else except chronic kidney disease.
That is
and
true.
I will say, yeah, we have everything else. Everything else, chronic kidney disease is pushed under the rug. And take away from high blood pressure, diabetes, and the use of the common medications that we spoke about, there's a family history of those patients that will progress to chronic kidney disease too.
Yes.
There are some patients that is inevitably will end up with chronic kidney disease, for example, or patients with polycystic kidneys.
Yes.
Or polycystic kidney patients needs to be referred, and if they can be treated, educated on how to slow the progress. Most of these patients, as much as we want to think, drinking more water, even though we said water and it sounds like a cliche, drinking more water, more diluted urine in those patients will help to reduce the progress of the whole cell formation and, you know, making things worse for those patients. Yeah. Most of those patients become high blood pressure quickly. And these are patients who end up start going downhill very early, 30 years old, you know, by the time they get to 40, 50 something, they may have already progressed. So there's a family component too. And our patients, don't forget our other patients too that are in the same category, our patients who have lupus.
Yes.
Yes, there are patients who have lupus. So that's why I said, know your numbers. When you go to see a doctor, don't just do lab work because doctor send you to the lab.
Tamara,
you would be call you with a phone call and say, lab's okay. What is okay?
You would be a very excellent advocate for kidney failure with a YouTube channel, putting out some education about this condition, getting some videos of what dialysis is like, you know, without putting the patient's face in the video, to show people what the dialysis process is like. You spoke about family support, and I remember when we were in Jamaica, even if the patients do not have the family support, we were the support, and we got very, very attached to those patients. I remember putting patients on the machine and then walking around and collecting money to go buy breakfast. So me, the big nurse, going to buy breakfast and taking order. And the patient would, don't mess up my order, don't mess up my order. Buy their breakfast, come back, make sure that they eat. And sometime at the end of the day, when you now leaving to go home, 1 or 2 patients still sitting in the waiting room, waiting for you to drop them home, or waiting for you to give them money for bus fare to go home after they spend the last dollar in dialysis.
Exactly. And I I remember, Cheryl, I sometimes want to get away from nephrology because it can be a bit taxing. It's quite a bit. But I find myself going back. My brother would always say to me, what else do you know? Sometimes I'm ashamed to say it after so many years on this earth. Anyway, I will never forget one evening, just the same like you said, dialysis patient, early, first shift, came in all the way from St. Thomas. Finished working, I walk into Papine. Who did I see? The guy at the bus stop. Like, you should probably reach St. Thomas and forget that you were in Kingston. So I stopped and I said, why are you still here? He said, I don't have any bus fare. And of course, you know, you had to go downtown and take something from downtown to St. Thomas. So I gave him money to pay his bus fare home. And it's so funny that the next day, another friend just said, here is lunch money. You know, it's like you said, you bless somebody and somebody bless you back.
Yes.
It's been a revolving door. It's been, dialysis patients are our family.
Yes.
And Cheryl, I will tell you, yes, they become family.
Yes.
We have had some who would just call the unit. You remember a particular patient who would say he is the CEO. And he wanted to know how many nurses were at work because he would be delivering lunch for us.
Yes.
Right? He would
Yes.
call and said, how many, this is so-and-so. I'm calling to see how many nurses are at work today. I am the CEO. And he would send lunch for us because he was so grateful for us.
Yes.
And I've met patients who have become family, truthfully family now.
Yes.
On dialysis. And I have a particular patient who's, like I said, family. And I had the privilege of traveling with him abroad to be transplanted. And he's still family.
Yes.
Unfortunately, now the kidney after 14 years has failed and he's back on dialysis. Okay. But we still talk every day. And so that is the patient that has become family.
Yes, they do, because I remember when I used to put patients on the machine. So for those who don't know about dialysis, first shift start at 5 a.m. So that means the first patient going on the machine at 5 a.m. So you, the nurse, have to be there like from 4:30 with the technician prepping those dialyzers, because in Jamaica, we reuse dialyzer. We don't have the privilege of just popping on a new dialyzer every time. So we are there. So once we put on these patients and everybody is settled, I get a chair and I sit beside machine number 1, talk to that patient, and they tell you all kind of story and you pop big laugh. After you finish with the patient, you move to the next one, because everybody waiting on you, you know, you better make sure you go around that circle and sit at everybody and talk to you, because everybody have something to tell you. And that is their way. They're dealing with a very chronic disease, a very a disease that's really, really emotionally burdensome, financially burdensome.
And physically too, because they're so worn after they leave dialysis, they're tired.
Yes, and it affects their personal life. It affects their marriages. Some people get impotence while they're on dialysis. Like, all of these discussion comes out when you're talking to these patients. You know what they're going through behind the scene. Chronic
anemia. Yeah, it is a life change, and you have to have a love for these patients, because they're a special set. There's one that will have you, you know, repeat the 21st Psalm, the Lord is my shepherd. And then there are others who give you the reason why you will continue. And I think that is in every area, but we more so know, you know, there are chronic patients who, you know, go through the mood swings. And it's so funny that ever so often, I would say to my social workers and, you know, ones that we talk well are, one of the things that I wish we had for our patient was counseling, because they're dealing with a chronic, disease, life-changing event, and it's depressing. So even though we can prescribe some antidepressant for them, I would hope at some point that they will consider some counseling for these patients, like a part of the bundle. But I guess
you know, we're already so burdened healthcare wise and cannot find the personnel that I'm not sure how they will bring somebody on in that realm, but it is needed.
Is needed.
It is needed because sometimes some of my visits are, their dialysis is going fine because I run in the outpatient and the dialysis is going fine. They're doing good. But it's a social, if parts of their life that outweigh their medical a lot of times.
Right.
That burden that comes with it, the social burden outweighs half of the time the medical burden.
Is there a National Kidney Week or day or month?
Yes, there is National Kidney, there's National Kidney Week, I think it's celebrated in September.
Okay.
In September, yes, it's celebrated, I think, in September each year. And even that too, unless somebody reminds you, or you walk into one of the centers, you see them giving out some ribbons, it's not celebrated.
Right.
It is not.
So what I need to do, hopefully this program will be around because I probably run out of healthcare professionals to interview, and I will be repeating those who have interviewed before. So hopefully that time I can bring you on to speak during that National Kidney Week to bring awareness. And I will reach out back to you if you want to come on, and then we discuss further as other aspects of living with CKD in terms of the cost, the medication. And we haven't even gone into the physiological changes that takes place in every single organ once you're diagnosed with kidney failure. I really appreciate you coming on today. And it was really, really an interesting discussion. And I'm sure this will create awareness to a lot of people. Their eyes will be wide open when they found out that certain medication that they were picking up over the counter, including myself, contributes to CKD over a period of time. Do you have anything to add before we end?
I will just reinforce what I said at the beginning is know your numbers when you go to see your primary care doctors. They love you, they care about you, yes, but ask a little bit more information about, see the trend. I have a few patients that I will give credit to. They come with a folder, and of course they want to let you hit your head because they have everything documented, but you appreciate those patients because they ask you for a copy each time so they can create that file for themselves to take to whoever needs to have it. So I'll encourage my patients, know your numbers, manage your diabetes well, high blood pressure, lose the weight, avoid anything that, drink enough water, stay hydrated under any circumstance, whether it be hot or cold. Again, if you have a family history, polycystic kidneys, history of kidney stones, someone with recurrent urinary tract infections, always ask about your numbers because you're exposed to antibiotics and these can further damage your kidneys. So I want to encourage everyone that your kidneys are precious, they're precious beings, and we need them for the rest of our lives.
And you only have two.
And you'll be surprised that some of us are only born with one. But we don't know because, of course, that's the only reason we can transplant one kidney and live with one kidney because you can live with one kidney. But of course, that would be incidental finding that we find out that you have one kidney. So again, know your numbers, at least visit your primary care doctor once per year. If you're a diabetic, which is diabetes, or people know high blood sugar, follow up with your primary doctors, take your medications as prescribed. Again, it's not a one size fit all. If you're not tolerating a medication, just don't stop it suddenly without talking to your primary care so they can find a substitute. Just don't stop taking medications because you feel better. And again, remember, the kidneys don't hurt unless they're obstructed or infected, or if you have polycystic kidneys and have a cyst that ruptured. So you can go unnoticed with chronic kidney disease until it has been severely damaged.
Thank you so much, Tamara, for sharing this information. Thank you for taking the time out of your busy day. I know you're a very, very busy lady, rounded in the hospital, going to the clinic, going to the center. I appreciate the service that you do. And I am so proud of you to know where we're coming from, to see both of us here together in Texas. We're in different area of practice. And before I end, we're still in Texas, Tamara. We need to see each other.
I'm waiting on the jerk chicken. All right, the title see it on Facebook.
All right. Take care.
All right.
Have a great
right.
day. Bye-bye.
All right, Cheryl. Bye-bye.
This was Ed Talk.